Welcome everyone to our second ACCP Transplant Peering webinar for 2026, Get in the Know, Nocardia Management in Solid Organ Transplant Recipients. My name is Dr. Kelly Goodlett. I'm an associate professor at Midwestern University College of Pharmacy and an ID research specialist at St. Joseph's Hospital and Medical Center. As a little bit about my practice site, we perform kidney and liver transplants, but our highest volume organ by far is lung transplant. We do over 100 procedures each year, and one of the first research projects I was involved with at St. Joe's was investigating nocardia cases in our lung transplant population. So this is a topic very near and dear to my heart. As disclosures, I've served on the Speakers Bureau for Merck and will be discussing off-label medication uses. And then our objectives for today are to assess the likelihood of nocardiosis based on patient risk factors, clinical presentation, and diagnostic test findings. We'll design an appropriate antibiotic regimen and therapeutic monitoring plan for a solid organ transplant recipient with nocardiosis. And then we'll evaluate recent evidence investigating the association between pneumocystis prophylaxis and nocardia infection risk. Specifically, looking at trimethoprim sulfamethoxazole, which I'll refer to as Bactrim. So let's talk about nocardia. Nocardia is an aerobic actinomycete, which includes a large and diverse group of filamentous gram-positive bacteria of varying pathogenicity. Some members of this group include Mycobacterium, Corynebacterium, Nocardia, and Rhodococcus. All members of this group have unique cell walls containing mycolic acid of varying chain lengths, which results in varying degrees of acid fastness on modified acid fast staining. The genus Nocardia is named after Edmund Nocard, who in 1888 described the isolation of an aerobic actinomycete from cattle with bovine farcy in the Guadalupe Islands. So Nocardia can infect our animal friends, though it's not considered a zoonotic disease. Instead, infection most often arises either by direct inoculation through the skin or more commonly in our solid organ transplant recipients by inhalation. In looking at the incidence in solid organ transplant recipients, on kind of the lower side, we have our kidney transplant recipients with an incidence ranging from 0.2% to 1%. And then on the other side, we have a wide range of lung transplant recipients from 1% to as high as 9%. Now, our lung transplant recipients, we know, have a higher burden of immunosuppression. We have the allograft exposure to the environment, as well as impairments in some of those innate pulmonary defenses that can prevent respiratory diseases. At our center, our observed incidence of nocardiosis after lung transplant was 3.4%. So what are some of the ways that we can turn up the dial on our nocardiosis risk? Well, T-cell mediated immunity and lung macrophages play a key role in local control of nocardia. Although cutaneous nocardiosis secondary to direct inoculation can occur in immunocompetent individuals, invasive nocardiosis really requires compromised cellular immunity. And so cases of severe disseminated nocardiosis in the apparently healthy should prompt assessment for an underlying immunodeficiency disorder. Risk factors in our transplant recipients have included underlying lung disease, older age, corticosteroids, high calcineurin inhibitor concentrations, recent treated episodes of acute rejection, as well as low lymphocyte counts, including due to cytomegalovirus infection. So essentially, anything that's going to increase our net state of immunosuppression is going to place our patients at increased risk for nocardiosis. So where can we find nocardia? Well, the answer is pretty much everywhere. Nocardia is a ubiquitous environmental organism both within the United States and globally, with the most common sources including soil, organic matter, and aquatic habitats. Less commonly, clusters of nocardiosis have been associated with healthcare settings and contaminated air or water, but more commonly, patients will be acquiring nocardia within the environment. Perhaps surprisingly, arid climates may actually have a higher rate of nocardiosis, which is likely due to the wind picking up and spreading nocardia in the air, which both increases acquisition risk from inhalation, as well as nocardia's overall geographic distribution within these regions. So within the United States, the southwestern US may have the higher incidence of nocardia. And then although the net state of immune suppression is the #1 risk factor for nocardia, cases in our transplant recipients may occur outside this classic window for a variety of reasons, but also potentially due to changes in patient lifestyle. So wanting to go out and travel and be in their gardens. So that's one of the benefits of organ transplantation, being able to have that new lease on life. But as pharmacists and healthcare providers, we should recognize the potential risks for environmental pathogens, including nocardia. Now let's take a look at an overview of some of our most common clinical manifestations of nocardiosis. So starting in the middle, you have primary pulmonary disease, which can be visualized as pulmonary nodules, infiltrates, and tree and bud opacifications on CT or chest X-ray. From there, nocardia may disseminate to virtually any area of the body, but the most common sites of dissemination are going to be the skin or the CNS. So cutaneous manifestations of nocardia, visualized as skin lesions, can be relatively common, with an alternative source of cutaneous nocardiosis being direct inoculation, which tends to be a less significant clinical presentation. By contrast, CNS nocardiosis is associated with some of our longest recommended treatment durations, 12 months or longer, and can be challenging for clinicians. Although any sort of CNS symptoms should prompt suspicion for CNS nocardiosis, over 40% of patients may have no associated neurologic findings. Therefore, brain imaging is indicated for all immunocompromised patients with suspected nocardiosis. The most common manifestation of CNS nocardiosis is a brain abscess, with meningeal involvement being uncommon. This potentially opens up additional potential treatment options beyond those that are used in the treatment of meningitis. So now let's take a look at a patient case. We have patient LB, a 68-year-old female who is 8 months post-lung transplant for interstitial lung disease. On her most recent surveillance bronchoscopy, a positive nocardia PCR test is reported. She is currently asymptomatic and has a negative chest CT. So the question is, what is the best action to take in response to this finding? 1, initiate antibiotic therapy. Nocardia should never be dismissed as a colonizer, even for asymptomatic transplant recipients. 2, initiate antibiotic therapy because while the result likely reflects colonization, colonized patients with immune compromise are at high risk for progression to clinical disease. Or 3, do not initiate antibiotic therapy at this time. So keep patient LB in mind, and we'll return to this patient case later on. So in the context of a compatible clinical presentation, culture, most often on respiratory samples, has represented our gold standard for nocardia diagnosis. And nocardia species tend to grow quite well in a variety of culture media and can be recovered in bacterial, fungal, and mycobacterial cultures. Most cultures will return positive for nocardia within 2 to 7 days, though in some cases, slow-growing species could require up to 2 or more weeks of incubation. So within this context, there has been increased interest in the use of molecular diagnostics, including PCR testing, to provide a more rapid diagnosis of nocardiosis versus traditional culture-based methods. It should be noted that clinical microbiology reference laboratories have access to broad-range bacterial PCR testing and sequence-based identification that can detect nocardia among other bacterial and fungal species. However, I'm going to focus for this presentation on the more accessible nocardia-specific PCR, which detects and amplifies a genus-specific 16S ribosomal RNA segment. Therefore, the results of this nocardia PCR do not include species information, and like any PCR test, do not provide information on antimicrobial susceptibilities for nocardia, which requires a positive culture. So the first test assessing nocardia PCR performance included 68 tests on clinical samples for patients with a compatible clinical presentation consistent with nocardiosis, as well as nocardiosis risk factors, including solid organ transplantation. From there, the patients were divided into the positive control group, where the patients were culture positive for Nocardia, and then the negative control group, where patients were culture negative and additionally had an alternate diagnosis that explained their symptoms or had documented improvement without Nocardia-directed antibiotics. From there, the authors used these group classifications and the Nocardia PCR test results to calculate the PCR sensitivity and specificity for nocardiosis. So for example, for sensitivity, there were 8 patients in the positive control group, 7 of which had a positive Nocardia PCR for an overall sensitivity of 7/8 or 88%. A similar process was used for specificity, taking the true negative PCRs over the true negatives plus false positives, resulting in a specificity of 74%. However, digging a little deeper, we see we have 12 essentially false positive PCR results. And all 12 of these false positives had been performed on respiratory samples versus other clinical samples of these patients. So the authors concluded that Nocardia PCR testing is a valuable additional assay for diagnostic evaluation of infections in immunocompromised patients, but that the interpretation of PCR results may be challenging because of possible detection of airway colonization. So again, Nocardia is an organism in the environment. It can be inhaled. It can be colonizing either transiently or for a longer duration, but that doesn't necessarily mean that the Nocardia is causing infection and actually invading that pulmonary tissue. So therefore, in the context of diagnostic stewardship, that begs the question of, is PCR positivity enough to make a diagnosis of nocardiosis? So the next study to try to address this question was a single center prospective study out of Europe that looked at Nocardia PCR testing in all BAL samples of 21 consecutive lung transplant recipients. Notably, in contrast to the prior study, this study included both clinical bronchoscopies, so in the setting of a compatible clinical presentation, as well as surveillance bronchoscopies. And what they found here was that the Nocardia PCR was positive on BAL fluid from 1/4 of all lung transplant recipients. However, none of the patients who tested PCR positive for Nocardia ever went on to develop culture positivity. And note that the follow-up duration used was quite long, so almost 2 years from PCR testing. Again, none developed culture positivity for nocardiosis or died. Additionally, most of the positive PCRs were in the surveillance group, but again, no patient developed nocardiosis. So the authors noted that PCR-based assays should be used with caution on respiratory samples in this lung transplant population, but given the small samples, that larger studies are needed. So that brings us to analysis from our center. So our transplant fellow was able to assess all of our BAL samples from 2020 to 2024, during which time period Nocardia PCR testing represented the standard of care on all samples. So this included, again, both surveillance and clinical BAL testing results. In contrast to the European study, we found a low rate of PCR positivity, just 1.7% out of all those 4,200 BAL samples, and versus 98% that were PCR negative. Investigating these patients and following them for a period of 6 months from testing, we assessed whether the patient was ultimately diagnosed with nocardiosis. So looking at our PCR false positives and true positives, false negatives and true negatives, we were able to calculate a sensitivity of the Nocardia PCR test for nocardiosis of 92%, a specificity of close to 99%, and a negative predictive value exceeding 99%. So on its face, this test performance appears to be even better than the initial study, but when we go into the positive predictive value of the PCR, so meaning we have a positive PCR result, can we use this to conclude that the patient has clinical nocardiosis, we see a very poor performance. So just 16% of patients who tested positive for nocardia on PCR would develop nocardiosis within 6 months. Teasing out this performance a little bit more based on clinical presentation, we found that when we limited the BALs to just the patients who had the clinical BAL, so in the context of compatible clinical presentation, and there were positive findings on CT suggestive of nocardiosis, the positive predictive value increased to a clinically meaningful 34%, whereas when we looked at the subset of patients who had negative CT findings, 0 patients with positive PCR results had clinical nocardiosis. So what can we conclude from these studies? So ultimately, we want to use caution before initiating nocardia-directed antibiotic therapy in the setting of PCR positivity alone. We also found that nocardia PCR is going to have very low utility as a surveillance tool in lung transplant recipients, but PCR may reasonably complement the diagnostic workup when infection is truly suspected. So this highlights the importance of correlating molecular diagnostics with the patient's clinical picture, including their symptoms, any imaging results, alternative diagnoses that are being considered, and known response or non-response to nocardia-directed antibiotic therapy. So then returning to our patient who had the positive nocardia PCR test on a surveillance bronchoscopy with no associated symptoms or radiographic findings, the best recommendation here would be to not initiate antibiotic therapy at this time. So now moving to our next patient case scenario, we have patient TM, a 71-year-old male with a past medical history of COPD and emphysema, who received a bilateral lung transplant 18 months ago. His current maintenance immunosuppression includes tacrolimus, mycophenolate, and prednisone. And at this time, he's presenting to your clinic with fever, cough, and decreased pulmonary function test findings. Now, in this case, the chest CT is significant for nodular opacities, and a BAL culture returns positive for Nocardia otitis discaviarum identified per MALDI-TOF. TM's additional medications of note include PJP prophylaxis with Bactrim, 1 single-strength tablet Monday, Wednesday, Friday, an estimated creatinine clearance of 30 mL per minute, and then other medications of omeprazole, alendronate, amlodipine, and vitamin supplementation. So take a moment to reflect now on which statement is most likely to be true regarding treatment of TM's nocardiosis. So 1, TM's empiric antibiotic regimen should include imipenem. 2, TM's nocardia isolate is likely resistant to Bactrim. 3, TM is at increased risk for linezolid toxicity due to renal impairment. 4, TM should receive a minimum of 2 active drugs for all stages of treatment, or maybe currently you're unsure. So again, we'll return to patient TM later in the presentation. So now let's talk about antibiotic therapy for nocardiosis. So first I wanted to reference the Clinical and Laboratory Standards Institute M24, which provides recommendations for susceptibility testing of mycobacteria, nocardia, and other aerobic actinomyces. So the antibiotics that are routinely tested for nocardia isolates include aminoglycosides, amikacin and tobramycin, fluoroquinolones, ciprofloxacin and moxifloxacin, 3 beta-lactams, amoxicillin clavulanate, ceftriaxone, and imipenem, 2 tetracyclines, doxycycline and minocycline, and then as kind of extras, we have clarithromycin, linezolid, and Bactrim. Clinical practice guidelines for the treatment of nocardiosis have been released by the American Society of Transplantation and last updated in 2019. However, it is important to understand that there are no prospective interventional studies examining any aspect of nocardia treatment, including duration, number of antibiotics, or choice of specific antibiotic. Thus, treatment recommendations have consisted of expert opinion and retrospective studies from the historical literature. But I can tell you, anytime I've taken a standardized test that asks what's the best option for treating nocardiosis, you're always looking for the multiple choice response that includes Bactrim and imipenem. So you can see the priority positioning of Bactrim and imipenem within the clinical practice guidelines, with a note that empiric combination therapy is recommended for severe and disseminated infection. I also want to highlight the long treatment durations that we're committing our patients to when we decide to treat them for nocardiosis, with 6 months on the shortest recommended duration and 12 months or longer with CNS dissemination. Now, I also wanted to highlight the guideline recommendation for susceptibility testing due to both inter and intra-species variability. So at our center, several years prior, we noticed a large number of nocardia cases being resistant to imipenem. Again, this was surprising to me as an infectious diseases clinician, given the priority placement of imipenem within nocardia treatment guidelines. So this prompted our team to investigate this phenomenon further and try to address the question of, is imipenem truly reliable for treatment of nocardiosis? Knowing our Nocardia species can give us some information on likely susceptibility to select antimicrobial agents. With the different clinical Nocardia species organized into 7 different complexes, again based on these predictive antimicrobial susceptibility profiles. It should be noted that Nocardia taxonomy has changed considerably over the past decade as a consequence of moving from phenotypic differentiation of species to those molecular identification methods that now represent the gold standard. Most notably, Nocardia asteroides, which used to account for over 80% of all of our clinical Nocardia isolates, has now been broken apart and split across numerous diverse species. So it is very important to interpret older literature cautiously, as the reported species susceptibilities and outcomes data may not align with current classifications. But if you look at our predicted species susceptibilities, you'll see that with very few exceptions, there is no one reliable agent active against nocardiosis, specifically when looking at our beta-lactams, right? So beta-lactams traditionally are antibiotic workhorses, right? They tend to have great efficacy, a favorable safety profile. But even if we look just at these predicted species susceptibilities, we can see that no one beta-lactam, and that includes imipenem, is reliably active against all of our Nocardia species complexes. So it's very important to recognize that beta-lactams do not have reliable activity as empiric monotherapy, and when used empirically for treatment of nocardiosis, should always be given in addition to another antibiotic with reliable and predictable susceptibility. Now, I do want to highlight that knowing the Nocardia species or complex may be adequate to infer beta-lactam susceptibility in some cases. So, for example, Nocardia nova tends to be very reliably susceptible to imipenem and may represent a reasonable option for empiric therapy. However, other species may have very significant variability depending on the study assessed and are not going to be reliably susceptible to any one beta-lactam. So this highlights the importance of really knowing your local Nocardia epidemiology, both your likely species within your geographic region and their associated susceptibility profiles. As an example, this study was put out assessing the most common Nocardia species and susceptibilities across the 3 geographically distinct Mayo Clinic centers. So what you can see is that within the different geographic regions, you can see some variability in terms of what are the 4 most common Nocardia species that were identified, as well as differences in associated susceptibility profiles. So for example, if we look at Minnesota, we see our most common Nocardia species being Nocardia nova, Nocardia farcinica, Nocardia seriosa georgica, and Nocardia abscessus. And looking at the reported susceptibilities within this article, there was high associated susceptibility to imipenem. So within Minnesota, imipenem would be a very reasonable option to consider among first-line empiric therapy regimens. By contrast, if we take a look now at Arizona, we see our most common isolates being seriosa georgica, farcinica, but now we also have 2 members of the Nocardia transvalensis complex, Nocardia wallaceae and Nocardia transvalensis. Both of these isolates were very poorly susceptible to imipenem, less than 20%, so this would be an indication to use caution before relying on imipenem within your empiric antibiotic regimens within this region. I also just want to emphasize again that Nocardia is not limited to the borders of the United States. And this article was looking at imipenem susceptibility across 9 microbiology labs in Israel. And you can see among the most common Nocardia species identified, very variable susceptibility to this agent across all species. So applying this regional species data, for example, to Arizona, again, we can more appreciate that imipenem is not going to be a reliable option for treating nocardiosis empirically. And then taking things a step further, at our site, we looked at all of our individual nocardia isolates and reported their susceptibilities. So you can see here for our beta-lactams, no beta-lactam was reliably active against all of our isolated Nocardia species, and imipenem, in fact, performed the most poorly among our species identified at 24%. Again, we saw that high resistance among members of the Nocardia transvalensis complex, but also had poor susceptibility among our Nocardia farcinica isolates. And that's particularly relevant given that Nocardia farcinica is a very common species across the US, as well as being arguably the most virulent. So looking at data both from our center and other published studies within the literature, murine models indicate potentially increased pathogenicity of Nocardia relative to other species, and in humans, Nocardia farcinica appears to be associated with an increased risk for disseminated disease, including CNS nocardiosis. We also observed increased mortality, which among our 5 patients who died of nocardiosis, 4 of these 5 patients were infected with Nocardia farcinica, making it a very important species to treat effectively right from the get-go. Finally, before we move away from our beta-lactams, I did want to address the question of whether our novel beta-lactam-beta-lactamase inhibitor combinations, so thinking of imipenem-relebactam, ceftazidime-avibactam, meropenem-vaborbactam, or even incorporating durlobactam, could these newer agents help us more effectively treat nocardiosis? Well, unfortunately, there are very limited data on the activity of these agents against nocardia isolates, but ultimately the outlook doesn't look so good. So first of all, nocardia have unique beta-lactamase enzymes distinct from our Enterobacterialis. These beta-lactamase enzymes can be associated with particular species, which contribute to their distinct resistance profiles. So for example, BLA-FAR1, which is found within Nocardia farcinica, contributes to its near universal resistance to ceftriaxone. By contrast, the BLA-AST beta-lactamase, or BLAST, found in Nocardia seriosa georgica, confers its near universal resistance to amoxicillin clavulanate. Now, a little bit more information about FAR1. FAR1 has been shown to potentially be inhibited by avibactam. However, this level of inhibition appears comparable to inhibition by clavulanate. Additionally, the addition of avibactam had no effect on the MICs for cefotaxime, imipenem, and meropenem. So overall, the clinical utility of adding avibactam to a beta-lactam regimen for Nocardia farcinica appears limited. Additionally, we know that beta-lactamase alone does not appear to fully explain Nocardia beta-lactam resistance patterns. So other mechanisms of beta-lactam resistance have been identified within Nocardia species not amenable to restoring activity using beta-lactamase inhibitors. These mechanisms include porn mutations, efflux pumps, as well as means of target site alterations, either altered PBPs or hyperproduction of the PBP drug target. Additionally, there are some mechanisms that we just haven't fully elucidated for nocardia. When we look at specific beta-lactam resistance genes, even if those aren't present, it is possible to see beta-lactam resistance among nocardia. So still a lot we don't know, but ultimately we're going to want to look outside of the beta-lactam class to identify different antibiotics that are going to be more reliably active against nocardia as empiric treatment. So what can we use? What antibiotics do have reliable activity against Nocardia? So our best players here are going to be amikacin, linezolid, and Bactrim. Amikacin I won't discuss in too much detail because it tends not to be a good contender for long-term nocardiosis therapy, but it could be a reasonable option with an empiric combination therapy regimens, though note that the nocardia transvalensis complex does represent a notable hole in sensitivity. So then our other options are going to be linezolid and Bactrim. So let's dive first into Bactrim. So Bactrim is the most utilized and best studied treatment for nocardiosis, with decades of historical evidence for efficacy, including as monotherapy. So we have very high predicted susceptibilities for our most common species, association of Bactrim use with potentially lower mortality or relapse risk, as well as from a pharmacokinetic perspective, excellent penetration into tissue and the CNS, as well as very high oral bioavailability. However, the drawback of Bactrim therapy is the potential for side effects, including myelosuppression, hyperkalemia, and gastrointestinal effects that can result in a discontinuation rate of between 15 and 40%. Now, I did want to acknowledge that some reviews will reference a study with very high Bactrim resistance reported. So this was a 10-year evaluation of Nocardia isolates submitted by state health departments to the CDC. In this article, they reported 42% Bactrim resistance, including 80% of Nocardia farcinica. However, and this was also acknowledged within the AST guidelines, subsequent studies have failed to corroborate these findings and again have reported very high Bactrim susceptibilities across all Nocardia isolates. While I don't know for sure why this study found such high rates of Bactrim resistance, one potential explanation is just the fact that Bactrim susceptibility testing for Nocardia is challenging. So if we take ourselves back to a microbiology class and MIC determination, within this picture we have broth microdilution wells where towards the top we have the lowest concentrations of the antibiotics, and then in dilutions of 2, higher concentrations of the antibiotics going down. You'll also see at the bottom for many of these wells a positive control showing nocardia growth and a negative control showing no growth. So if we were to try to determine the minimum inhibitory concentration of ciprofloxacin for this nocardia isolate, so again, column A, we would end up with an MIC of 4. So our first concentration, the lowest concentration where we see no growth of nocardia. Unfortunately, this MIC of 4 corresponds to resistance to ciprofloxacin. Now let's take a look at column B. So in this well, we have tobramycin. So what is the MIC of this nocardia isolate to tobramycin? Well, we still see nocardia growth at the highest concentration of 32, and therefore the MIC would be reported as greater than 32. Again, this is going to be a resistant phenotype. Now, how about our Bactrim in column C? You may have guessed that the MIC would be greater than 4/76 due to the presence of nocardia in these wells. However, the Bactrim MIC is actually 2/38 for this isolate, which would correspond to a phenotype of susceptible. So false reports of Bactrim resistance may occur due to difficulties in endpoint determination. So for nocardia, the Bactrim MIC should be reported as the drug concentration where approximately 80% growth inhibition is observed, or the first concentration where there is notably decreased growth, not the drug concentration that fully inhibits visible growth. So several drugs have been shown to give false resistance, again, Bactrim being the main culprit. So anytime you have Bactrim resistance reported on broth microdilution, it is important to verify these MIC results using a DIS diffusion test. False resistance have also been reported for select isolates to ceftriaxone or as well select isolates to imipenem, usually as a result of inadequate interpretation. So how can we use these results? Well, ultimately, nocardiosis susceptibility testing may not be the right time to go it alone, and you should consider isolate send out to laboratories with expertise in nocardia testing for the most accurate species identification and AST interpretation. At minimum, we should view Bactrim resistance with a healthy sense of skepticism and ensure that this resistance has been verified using more than one testing methodology. So now moving on to Bactrim to our other member of the antibiotic A team, linezolid. So benefits to linezolid is near universal susceptibility, as well as excellent PK distribution to affected body sites, including the CNS. While data are limited, generally favorable clinical experiences have been reported with initial linezolid treatment. So in these two case series, there was an associated 85% or 93% cure of nocardiosis, and 20 cases of patients treated with linezolid for a median duration of 3 to 4 weeks. So we're not necessarily talking about a full 6-month duration, but again, having linezolid as a reliable empiric option. However, within these two studies, we do note some differences. So in the Davidson 2020 study, 80% were able to successfully complete the intended duration of linezolid therapy, and the incidence of thrombocytopenia was 45%. By contrast, in the Below de la Cruz study, only 27% of patients successfully continued linezolid therapy until final nocardia susceptibilities, and 93% of patients had reported thrombocytopenia. So what are some potential explanations for this finding? We'll come back to this in a couple slides. I also want to highlight another potential concern. So again, nocardia isolates are reliably reported susceptible to linezolid, which is amazing. But it should be acknowledged that looking at the MIC breakpoint, so the highest possible MIC the organism can have and still be reported as susceptible, is notably higher for nocardia species relative to some of our other common gram-positive organisms. This means that nocardia species could have an MIC of 4 or 8 and be considered susceptible versus that same MIC would be considered intermediate or resistant to many of our other gram-positives. So there's really sparse data on clinical outcomes evaluating these higher MIC isolates. And again, Nocardia farcinica, or big bad, commonly does have MICs at or near this clinical breakpoint. So the question is it actually even feasible to kill an isolate with an MIC of 4 to 8 using our conventional linezolid dosing strategies, which were not tailored for nocardiosis? So again, limited data. There is no established PK/PD parameter for clinical treatment success for linezolid and nocardia. However, our PK parameter for other conventional gram-positive organisms includes an AUC to MIC ratio anywhere between 50 to 100 or 80 to 120. Notably, in one population PK model, there was only a 7% likelihood of achieving a target AUC to MIC of over 100 when the bacterial MIC was 4. In another study, when you had a patient with overweight or obesity, a dose of 600 milligrams every 8 hours as opposed to 600 milligrams every 12 hours, was noted as potentially required to achieve pharmacodynamic targets at an MIC of 2 or greater, but that increased dosing strategy may not even be adequate for an MIC of 4 or higher. We also know that critical illness, as is common in transplant recipients, increases the risk for both over and under exposure to linezolid. Going back now to considerations for longer-term linezolid, so we know that as treatment duration increases, patients appear to be at heightened risk for hematologic toxicities. And notably, renal impairment has been increasingly recognized as a risk factor for an increased likelihood of toxicity development. In a patient meta-analysis of over 3,500 patients, a 2.5-fold increased odds of thrombocytopenia was reported if the patient's creatinine clearance was less than 60 mL per minute. So we know that linezolid does not traditionally come with renal dose adjustments. However, renal clearance does account for 30% of linezolid's renal elimination, as well as 90% of the elimination of its active metabolite. So therefore, it is possible, particularly for these longer treatment durations, for linezolid concentrations to accumulate in patients with renal impairment. So now going back again to our two Nocardia studies, in the Davidson trial, where the incidence of thrombocytopenia was 45%, only 20% of the patient population was known to have chronic kidney disease. By contrast, in the De La Cruz study, where the incidence of thrombocytopenia was notably higher, over half of all patients had a creatinine clearance less than 60. So again, this may explain the higher observed incidence of thrombocytopenia and the decreased tolerability of linezolid therapy in this population. Other factors that have previously been associated with increased linezolid exposures include older age and P-glycoprotein inhibitors, which include clarithromycin, PPIs, amiodarone, and calcium channel blockers, all of which may be encountered in our transplant recipients. So then the question comes, well, can we help things out using therapeutic drug monitoring? So there are recommendations for trough-guided TDM of linezolid, most often using a goal range between 2 and 8, which correlates with a predicted AUC of greater than 80. Linezolid concentrations within this therapeutic range have been associated with the lower incidence of thrombocytopenia, and TDM-guided dose reductions may allow platelet recovery and completion of planned treatment duration. However, it should be noted that comparatively few clinical data describe TDM-guided dose escalation as potentially as needed for higher MIC isolates. Though there was one single case report of a patient receiving hemodialysis who initially discontinued linezolid due to thrombocytopenia, who was able to be successfully continued on linezolid using the help of TDM and a reduced dosing strategy. So overall, linezolid hematologic toxicity is common and associated with increased concentrations. Dose reduction may be considered with longer duration therapy to prevent or manage toxicity, but really we want to fuel linezolid with a little bit of caution when we do have some of these higher MIC isolates, particularly for patients with preserved renal function. So maybe linezolid monotherapy maybe should be avoided in those patients. But again, it can be a very reasonable empiric option. I also want to note that tedizolid represents another option for nocardiosis treatment, and we can confirm tedizolid susceptibility from linezolid susceptibility results. So a transition from linezolid to tedizolid is also another option for mitigating some of the thrombocytopenia associated with linezolid therapy. Looking into just a few other aspects of nocardiosis treatment is the question of treatment duration. So traditional non-CNS minimum duration of nocardiosis treatment, as noted in the AST guidelines, is 6 months. And this longstanding recommendation tends to be derived from historical data looking at a relatively low dose of Bactrim, where it was a lower duration of less than 3 months was associated with a numerically increased risk for relapse compared to a 4 to 6 month duration. But it should be noted that we're looking at very small patient numbers, relatively low doses of Bactrim, and again, not all patients received a full 6 months treatment duration. So a few studies subsequently have looked at treatment duration and associated nocardia outcomes. So a couple studies listed on the bottom did associate an increased risk for relapse with a shorter antibiotic duration, generally less than 120 days. However, the authors did note that relapse cases tended to still have good clinical outcomes. By contrast, the two above studies did note that shorter durations, including 2 to 4 months of antibiotics, or even less than 120 days, still had good clinical outcomes, including in solid organ transplant recipients. So some patients can tolerate shorter durations, though there may possibly still be an increased risk for relapse. So how do we put these data together? I would ascertain that shorter duration antibiotic therapy could be cautiously considered for pulmonary or cutaneous nocardiosis on an individualized basis. So ultimately, clinical and radiographic response, as well as adverse effects, should be considered when determining the endpoint of nocardiosis therapy. We're taking that 6 to 12 months duration as kind of an aspirational goal, but with a final duration modified as needed according to clinical response and patient tolerance. So if you're able to get your patient to 5 months of antibiotic therapy, they've had a clinical response, but they're just not tolerating their Nocardia antibiotics anymore, rather than going through Herculean efforts to keep them on antibiotics or try to go to second line or third line agents, it may be completely reasonable to stop therapy there and just monitor the patient to assess for potential relapse. And then finally looking at the issue of 1 versus 2 antibiotic. So in contrast to mycobacterial infection, there is no evidence that combination therapy improves outcomes in nocardiosis once we have final confirmed susceptibilities. And again, Bactrim in particular has strong supporting evidence as monotherapy for nocardiosis treatment. In one of our controlled studies, early use of 2 versus 1 active antibiotics was not associated with decreased mortality in solid organ transplant recipients. So again, the most important thing is to have 1 active antibiotic on board. Initial combination therapy can help facilitate that, but having more than 1 does not appear to lead to increased synergy or better therapeutic outcomes. By contrast, looking at the harms, unnecessary combination therapy could increase costs for the patient as well as the risk of developing an adverse drug event, which we know can result in shortened treatment durations overall. So while combination therapy may be reasonable in some circumstances and definitely is reasonable for empiric therapy, overall, we want to look for opportunities to streamline our antibiotic regimens when feasible. So in looking at some modified recommendations for treatment, again, for initial therapy, the most important thing is to select at least 1 agent that's going to be reliably active against Nocardia. And again, Bactrim and linezolid are going to be some of our front runners there, with potential consideration for amikacin. IV beta-lactams are certainly appropriate within combination empiric therapy regimens, but in most circumstances should not be relied on as monotherapy until we have confirmed susceptibilities. Bactrim is an excellent option for maintenance oral therapy. However, other drugs may be considered with confirmed susceptibility. And then for duration, while 6 months tends to still represent our standard, shorter durations may be considered for select patients with treatment-limiting adverse effects and early clinical response. However, with CNS involvement, we do still want to have prolonged durations whenever feasible. Now I'm just going to finally conclude with looking at the issue of Bactrim prophylaxis for pneumocystis and whether Bactrim can also offer protection against nocardia. So first of all, it's important to recognize that nocardiosis may occur despite Bactrim prophylaxis for PJP. So you can absolutely have cases of nocardiosis in a patient who's already receiving Bactrim prophylaxis. So the question is whether Bactrim could offer partial protection, and that's an issue that has historically been controversial. So within the 2019 AST guidelines, they suggest that Bactrim prophylaxis may be helpful, while giving it a weak recommendation supported by very low quality of evidence. However, during the same time period, you have other review authors arguing that Bactrim prophylaxis is not effective to prevent nocardiosis, most often citing these older 2 case control studies that failed to identify a statistically significant protective effect of Bactrim. However, if you look at these studies, the odds ratio between Bactrim use and nocardiosis risk was on the good side, right? And then there were also some other limitations. So less than 25% of control patients in the Right European study were receiving Bactrim, limiting statistical power. Relatively low doses were used, and no information tended to be provided on adherence. So we know it's relatively common for Bactrim prophylaxis interruptions to occur secondary to leukopenia or renal impairment, again potentially limiting the ability to find an association with nocardiosis prevention. So our group was very skeptical that these studies, while wonderful advancements in our knowledge of nocardiosis, truly represented the definitive answer on does Bactrim help prevent nocardia infection, particularly again in our lung transplant recipients who, as noted, are at higher risk for infection and were underrepresented, particularly in the 2016 study. So our group, over a period of 2012 to 2018, looked at our lung transplant recipients, identified 20 cases of nocardiosis, and matched these patients based on sex, age at transplant, and date of transplant 2-to-1 with a matching control. And then we performed a regression analysis looking at nocardiosis risk factors. So first of all, I wanted to highlight the prophylaxis regimen that these patients were receiving. So you can note that among our control patients, Bactrim use was very common, over 90%, compared to only about 65%, only 60% for consistent use among our patients who developed culture-proven nocardia. So then when we performed our multivariable analysis, we identified two significant factors with augmented immunosuppression increasing the risk for nocardiosis versus consistent use of Bactrim prophylaxis decreasing the risk for nocardiosis. So again, found a statistically significant association of Bactrim prophylaxis exposures to reduced risk for developing nocardia. Subsequent to this time period, an additional multi-center case control study of 123 solid organ transplant recipients with nocardia was put out by the 3 Mayo centers, which, consistent with our findings, found reduced odds of nocardia infection when Bactrim prophylaxis was given. So this prompted the creation of a meta-analysis assessing these different cohort studies to try to determine whether there was an effect or a protective role of pneumocystis prophylaxis with Bactrim in reducing nocardiosis risk. Ultimately, Bactrim use was found to be statistically significant in reducing the risk for nocardiosis, with results concordant whether using the study level data analysis or the individual patient level data analysis. An important element also to note from this meta-analysis was that breakthrough infections had a high susceptibility to Bactrim. So meaning if a patient was receiving Bactrim as pneumocystis prophylaxis, this did not appear to be associated with an increased risk for Bactrim-resistant nocardia. In fact, the pooled susceptibility to Bactrim among these breakthrough infection isolates was 98%. So again, trim sulfa is sublime and a reliable option for nocardia treatment. Now, since there's been a little bit of a Bactrim renaissance on additional literature published on Bactrim use in solid organ transplant recipients, so just as a little bit of a summary from these findings, early Bactrim discontinuation due to adverse effects remains common. However, a significant proportion of solid organ transplant recipients do tolerate Bactrim initiation after initial intolerability. So while reinitiation wasn't necessarily performed commonly, the data suggests that when it is performed, a very significant proportion of our transplant recipients can then be continued on Bactrim for the duration of intended prophylaxis. The data also provided some additional support for Bactrim and nocardia protection. However, prolonging pneumocystis prophylaxis solely for the purpose of OI prevention or collateral benefits was identified as unlikely to be of value in low-risk solid organ transplant recipients. So as pharmacists, we can help support sulfa stewardship and recognize as a myth that Bactrim allergy or intolerance truly necessitates use of second-line antimicrobials for prophylaxis. So we already mentioned that when Bactrim is held or discontinued due to adverse effects, a large proportion of solid organ transplant recipients will tolerate Bactrim reinitiation. Additionally, reduced Bactrim dosing strategies appear to maintain high pneumocystis protection among solid organ transplant recipients and may help improve tolerability. As pharmacists, we can also evaluate opportunities to mitigate overlapping toxicities via other modifications to our patient's drug therapy. And then I also want to mention that a large majority of patients with sulfa allergy, including immunocompromised populations, may be successfully delabeled of their sulfonamide reaction using an oral challenge protocol. So this protocol comes from the American Academy of Allergy, Asthma, and Immunology, as well as the American College of Asthma, Allergy, and Immunology. So again, they recommend either a one-step or a two-step oral Bactrim challenge, depending on the patient's documented sulfonamide reaction, and in some cases, how long ago the reaction occurred. So this can provide an easy and effective means of delabeling select patients without requiring skin testing. So now going back to patient TM. So the answer here is that TM is at increased risk for linezolid toxicity due to his renal impairment. So TM's Nocardia discaviarum is likely imipenem resistant based on predicted species susceptibilities, so choice 1 is false. For choice 2, Bactrim breakthrough is not a risk factor for Nocardia resistance, and over 95% susceptibility is anticipated. So again, that option is false. TM has numerous risk factors for linezolid toxicity, including older age, renal impairment, PPI, and calcium channel blocker use. So choice 3 would be true. So if longer-term linezolid therapy is being considered, TM could benefit from linezolid TDM, reduced dosing, or consideration for switch to tazezolid. And then for option 4, although empiric use of multiple antibiotics is generally recommended with severe infection to ensure at least one is active, monotherapy may be used once susceptibility has been confirmed and may reduce toxicities. So overall, we want to recognize that innate and acquired cellular immunodeficiencies increase the risk for nocardiosis. Knowledge of local Nocardia species and resistance patterns is really key to best direct empiric therapy. And it's important to recognize that guideline recommended options do not always represent optimal therapy across all transplant centers, but being attuned to patterns and unexpected findings in your local transplant population may spark nationally relevant research investigations. Next, Bactrim is boss, Trimsulfa is sublime, and should preferentially be used as pneumocystis prophylaxis and within nocardiosis regimens. Importantly, Bactrim rechallenge following adverse drug events is usually successful among transplant recipients. Linezolid has very reliable nocardia activity in vitro. However, achievement of conventional PK/PD targets at higher MICs could be unlikely for patients with preserved renal function, so just use caution before using linezolid as monotherapy in this scenario. And then finally, pharmacists may promote a nocardia antimicrobial stewardship via appropriate diagnostic test interpretation, including for nocardia PCR, shortening antibiotic duration in eligible patients, and streamlining antibiotic regimens. So thank you for your time, and I'm happy to answer any questions via email. Otherwise, thank you for attending this Transplant PRN webinar.